Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse, as well as CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. We would like to thank our following partners for supporting today's webinar. At this time, I would like to introduce our moderator, Dr. Brian Kaufman, who is CLL Society's Executive Vice President and Chief Medical Officer.
Thank you, Robin. I would like to welcome our audience and speakers to today's event. We are joined by Dr. Shahzad Mustafa, an immunologist and the lead physician and clinical associate professor of medicine at the University of Rochester School of Medicine and Dentistry, and also by Dr. Andreas Chang, a hematologist and instructor at the Winship Cancer Institute of Emory University. Robin Brumble, who's the Director of Scientific Affairs and Research at the CLL Society, will walk us through CLL Society's COVID-19 action plan and the importance of being prepared. All our speakers will be sharing brief presentations, but the majority of today's event is going to be dedicated to your questions. It is my pleasure to now introduce Dr. Mustafa. Dr. Mustafa.
Hi, everyone. My name is Shahzad Mustafa. I practice allergy and clinical immunology in Rochester, New York, and I'm flattered to be here today to discuss prevention of COVID-19 and CLL. Our learning objectives today are to understand special considerations regarding COVID-19 for individuals with CLL and to understand the current strategies for prevention. As Dr. Andreas Chang will later discuss about treatment, we both agree that prevention is desirable as compared to treatment. The vaccination in CLL has some caveats that we want to be aware of. So we all know that vaccines lead to antibody production. We've heard a lot about this over the last couple of years. B cells make antibodies. So these are the cells in our immune system that really generate antibodies, IgG. We've heard of that as well. You guys know that CLL is a B cell cancer. And therefore, B cells are dysfunctional in CLL. So it doesn't take much of a leap of faith to realize that patients with CLL may have suboptimal antibody responses since their B cells are not quite working up to snuff. We've known this for decades, and many previous studies have shown that when you vaccinate individuals with pneumonia vaccine or tetanus or influenza, their antibody levels, which should shoot up, you should see those lines going up, are often flat. So we've known for years that vaccination in CLL is suboptimal. It can still be helpful, but it's suboptimal as compared to a general population. And this remains true for vaccination for COVID-19. This was a great study published on individuals with special health considerations and their response to COVID-19 and how many vaccination and how many people responded to vaccine. You see the group that responds least well is individuals with solid organ transplant who are on subsequent immunosuppression. They really have a very poor rate of converting from no antibodies to significant. But look at the second group. It's individuals with blood cancer. So a group, about 50% of folks do respond and 50% don't. But folks with blood cancer is a huge diverse population. So looking more specifically, the ones who are least likely to respond and make adequate antibodies are folks with CLL. It's about a 50-50 bet. 50% of people generate detectable IgG antibodies and 50% don't. And on the graph below, it shows that even the 50% that do, the amount of antibodies they generate are far less than individuals with other blood cancers. So here we definitely see that our response to COVID-19 vaccination from antibodies is suboptimal for a significant amount of individuals with CLL. But that doesn't mean vaccination is not helpful, and it's still highly recommended, and I think it's our #1 strategy for disease prevention. This is a study that was just published on how your antibody levels increase with subsequent vaccinations. So the first to the second dose gets a lot, about 50% of people home, but not many. But a second dose gets people even higher, and then subsequent doses continue to increase your antibody levels. So this is a very, very recent study, and it shows the importance of staying up to date with your vaccination series. Obviously, the original 2-dose series, but then beyond as well. And this is true regardless of if you have CLL and you've never had treatment, you were on treatment or off of treatment, or if you're on treatment. Regardless of where you are in your journey with CLL, subsequent vaccinations tend to boost your immunity. And that's what we want from booster vaccines. So that remains important. This has been demonstrated in patients with CLL. If you're not responding as well to the vaccines, is there another way to get you antibodies? And there has been. Folks have probably heard of Evusheld. And this was a study published that showed that individuals who were at high risk for COVID-19, if they were given Evusheld, their likelihood of getting infection, a COVID-19 infection, went down. High risk in this study did not include many people with blood cancers. There was other reasons: age, diabetes, other cardiac conditions, other health history, but very few of these individuals actually had hematologic malignancy or CLL. We published our experience of individuals, over 200 individuals with hematologic malignancy who got Evusheld. And what you see here, and over half of these folks had CLL, individuals in our center who had blood cancers, including CLL, who got Evusheld had a lower likelihood of getting COVID-19, symptomatic COVID-19 infection as compared to the general population. So we do believe that Evusheld has been protective and helpful in even individuals with CLL. The problem is viruses, and Dr. Chang is going to discuss this, are always mutating, and there's new variants. And unfortunately, the most recent variants, as you've heard, do not seem to be captured by Evusheld protection. So you see on the right, these are individuals who had low antibody levels, got Evusheld, and had higher antibodies against COVID-19. But on the right side of this, these new variants, what we call these Scrabble variants, the Qs and the Xs, really do not have much. Evusheld has very little activity against these new variants. So this is not surprising. We expect this with virology over time and mutations and changes, but it is disappointing. Although still authorized for use as of today, Evusheld, the effectiveness, the efficacy is certainly less than before, but it is, as of today, still authorized for use in high-risk individuals. Another way to get antibodies, if you're not just responding to vaccines, is through immune globulin replacement. Now, certainly no one, and I'm not ever suggesting anyone with CLL or any condition should go on immune globulin replacement to get COVID antibodies. But for individuals who might already be on immune globulin replacement, you should know that immune globulins obviously come from blood donors, right? Human plasma. And most donors who have given in the last year to year and a half to 2 years have their own COVID antibodies. So that is passive immunity. So if you are getting immune globulin replacement today, there's a very, very high likelihood that there are COVID antibodies in your immunoglobulin formation, whether it's intravenous or subcutaneous. So the way I see risk mitigation and prevention of COVID-19, it's a multi-layered process. There's nothing that's perfect. We certainly want to adhere to common sense social considerations. You know, going to a stadium without a mask with 100,000 people may not be the smartest thing to do. So we want to be thoughtful about the things we're doing and how we're doing them, not necessarily not doing things that we want to do. You certainly want to minimize unnecessary immunosuppression. If there's drugs that you don't necessarily need to be on, try to get off of them. We're always thinking of this in medicine, of course, less is more. Absolutely, the take-home point is everyone should complete their vaccination series, and even if it's suboptimal compared to the general population, it certainly still has effectiveness and is safe. And then to consider other ways to get passive immunity. If you can't make your own antibodies from vaccination, what are other ways to get antibodies? And Evusheld is an option, or potentially IG replacement. None of these are perfect. They all have imperfections. They have pros and cons, but put together, you give yourself a best chance of protecting yourself from COVID-19. And with that, I want to hand it off to Dr. Andres Chang, who's going to be talking about when prevention potentially fails, therapeutic options. Thanks.
All right, good afternoon. First of all, I want to thank the CLL Society for the opportunity to give this talk. My name is Chang, and I'm an instructor at the Department of Hematology and Medical Oncology at the Winship Cancer Institute of Emory University. So today, I would like to first give an introduction about SARS-CoV-2 variants, what they are, where they come from, and what their implications are to human health. And then I would like to discuss the COVID management strategies of COVID-19 disease in the context particularly of CLL. So what are all these SARS-CoV-2 or COVID variants that we hear in the news? Well, they are SARS-CoV-2 viruses that have undergone mutations in its genetic code so that they now look and behave a little different from their ancestral parent virus. This is an expected and a natural process that occurs as part of viral evolution. And it occurs also with other viruses, like the flu, for example, which is partly the reason why flu vaccine formulations change from year to year. Through this process, more fit viruses will replace less fit viruses. This means that variants with mutations that confer some sort of a growth advantage to the virus will survive and take over less fit variants. This growth advantage can be in many different forms, including increasing infectivity, improving their capacity to escape our immune systems, or to resist therapies, just to name a few. Now, the CDC actually tracks the emergence of these variants and reports them to the public through the CDC data tracker, so that you all can access and look at how this process is taking place essentially on a weekly basis. With many of these variants, the newer variants here, showing here as of last week, taking over ones that were more prominent and more common during the summer and early fall. Now, the management of COVID-19 disease is rapidly evolving, with agents coming and going as the virus evolves and we get new data. So what I'm about to discuss here are current approaches applicable to individuals who are at high risk of severe disease, including older patients and patients with compromised immune systems, like those with lymphomas and CLL. And so, first of all, one thing that I wanted to stress is that it is essential that patients who test positive for COVID contact their providers as soon as possible so that treatment can be initiated within the first 5 days of symptom onset. This is because these treatments work better the earlier you start and you get on them. As of today, there are 2 approved oral treatments for COVID-19 infections, nirmatrelvir, ritonavir, marketed under the trade name Paxlovid, and molnupiravir, marketed as Lagevrio. Both of these medications are taken twice per day for 5 days, and they have shown to reduce the risk of hospitalization and death, both in articles published last year. They have different side effects and drug-drug interactions, so patients should talk to their providers about which one is the right medications for them. Now, there are other medications available in the outpatient setting. These include remdesivir, which is an IV medication, and in select cases, patients can receive convalescent plasma with high anti-SARS-CoV-2 titers. Unfortunately, though, we no longer have any approved effective monoclonal antibody therapies for the treatment of COVID-19 disease. Now, you might have heard that some patients treated with these medications get so-called COVID rebound. This simply refers to when patients have worsening symptoms and have higher amount of virus in their bodies after stopping treatments when they initially have an improvement of these parameters. This occurs in a small percentage of individuals, regardless of the treatment they receive, and has even been documented in patients taking no active medication, as you can see in this graph over here from this particular report. It likely means that that particular patient was undertreated, but at this point, it is not clear whether the effect of having a rebound really has any clinical significance. Treatments for COVID-19 change for patients who have more severe disease and require hospitalization. Management of these cases depend on the severity of the disease, but in general, most immunocompromised individuals will receive remdesivir, and depending on their clinical condition, one or more agents that will modulate the inflammatory process. These agents will include things like steroids, for example, most commonly dexamethasone, but also inhibitors of molecules that result in inflammation, such as JAK kinases and interleukin-6. I've listed here some of these agents that have been used for the treatment of COVID-19 disease, and you might see them being used in certain circumstances. Importantly, hospitalized patients should all receive some sort of a blood thinner to prevent blood clots that might result both from hospitalization and from COVID infections. And also, they should receive supportive care measurements like supplemental oxygen and so forth. And so in conclusion, the emergence of COVID-19 variants is a natural and inevitable process. Some variants will cause worse disease than others. An early initiation of treatment is essential. We have 2 good oral regimens that we can give in the outpatient setting, but unfortunately, we have no monoclonal antibodies that are available for treatment at this point. However, there are new treatments that are coming on the horizon. Most notably, there's this recent report published last week showing a new type of medication that shows similar efficacy compared to our combination treatment that is currently available. And then I want to stress finally that preventing infection is much better than treating infection. And so with that, I want to thank you very much for your attention. And now I want to introduce our next speaker, who is Robin Brumble from the CLL Society.
Hello, everyone. My name is Robin Brumble, and I'm going to review CLL Society's COVID-19 action plan with you today. The reason behind why CLL Society put together a COVID-19 action plan is because in early 2021, those in our community were reaching out to CLL Society after having either known exposure to COVID-19 or receiving a positive test result, and many weren't quite sure what to do. Since that time, we have made several updates to the action plan. And as we know, the only constant throughout the pandemic has been continual change as new data emerge and treatment recommendations are often updated. Since this document has been updated multiple times, the plan has been created based on the most recent recommendations. So please make sure you have the most recent version available to you by checking the dates of when each document was last updated. The COVID-19 action plan is comprised of several checklists that we highly recommend individuals fill out before COVID-19 impacts your home. If you have not already, we highly recommend that you spend some time reading through the directions and filling in the blanks as they apply to your unique situation. Then print out the completed checklist if you can, and keep your personalized plan in an accessible place so that you can easily refer back to the plan when you need to. I'm going to very briefly go through the different pieces of the plan and provide some screenshots. The first 2 pieces of the plan include reading through the detailed step-by-step directions and then filling out the corresponding checklists that is called Complete Prior to Exposure. The intent of these first 2 documents is to guide you through exactly what you need to do far in advance of getting COVID-19. Some advanced planning is highly recommended as time is of the essence in finding and obtaining COVID-19 treatments after an infection has been confirmed. And some have reported to us that if they waited to plan until they confirmed their infection, it has sometimes taken several days to figure out where they need to go, determine what locations have those COVID-19 therapies available, and then having to take additional time to make appointments to actually obtain those therapies. Some important things that these first 2 checklists will walk you through include looking up important phone numbers you will need to call ahead of time, keeping a suggested list of supplies readily available, as well as how and where to quickly obtain those COVID-19 therapies if needed. The next 2 checklists include what to do if you have known exposure to COVID-19 or a positive test result. These two documents will guide you through exactly when you should obtain a COVID-19 test after known exposure, how long to monitor for symptoms after exposure, and perhaps most importantly, how to adequately quarantine and isolate. If you aren't quite sure what steps you should take to try to keep from getting COVID-19 from someone else in your home who has already tested positive, please read through this checklist so you can be well informed and prepared. It is, in fact, possible not to become infected from someone you live with if everyone takes the appropriate infection control precautions as soon as infection is suspected, and especially after infection is confirmed. The next checklist I will be sharing with you is perhaps the most important. It tells you exactly what things to do after testing positive for COVID-19. This checklist reminds you of the steps to take early on, which again is key. One of which is to call your healthcare provider immediately to discuss any COVID-19 therapies that you are eligible for as soon as possible. It will also prompt you to keep a log of your vital signs and symptoms, what to remember to do should you need to seek emergency medical care, and steps to take to make sure your illness has run its course and you are no longer infectious, which can sometimes take quite a bit longer in those who are immunocompromised. You can find all of these checklists on our website at cllsociety.org. As you can see in the screenshot of our website, there is a COVID-19 title located near the top of our homepage on the menu bar. If you click on that from the homepage, it will then take you to our dedicated COVID-19 information page. Then in the middle of our COVID-19 information page, you will see an option that says COVID-19 Action Plan. After clicking on the action plan, you will be directed to the page where you will find all of the checklists that I have reviewed with you today. Please remember the COVID-19 action plan is there for you on our website whenever you need it, but we highly recommend you access it ahead of time before you are exposed or before you start to feel ill. Doing so will help you have a better peace of mind, knowing exactly who you plan to call, what supplies to have on hand, and what to do should you or someone else in your household become infected. After you complete your COVID-19 action plan, we suggest you keep your checklists in a folder, place them in an easily accessible place so that you can find them. It's also extremely important to discuss your plan with everyone in your household so that they too can know what to do and what to expect should anyone become infected. And please remember, if you do have known exposure, any symptoms, or if you have a positive test result, act fast. Even if you don't have symptoms yet, please call your healthcare provider right away because obtaining available COVID-19 therapies as soon as possible remains to be one of the very most important things you can do to achieve your best outcome. This is especially true for those with CLL and SLL. Thank you, keep learning, and please stay safe.
Hi, Dr. Brian Kaufman here. First, I want to thank all our speakers. I always learn from these webinars, and I thought we had some great presentations today. And I do really want to echo what Robin had to say. Our COVID action plan, I think, can be a lifesaver, and I think it's worth taking a look at. And to their credit, the CDC saw the light and have developed their own COVID action plan, which strongly mirrors what we've done about a year after we did it. So I think we were pushing in the right direction. We have some poll questions to start with. Please scroll down to read all the questions, and I'll start reading a couple of them to you. Without the protection of Evusheld, and we heard how it is no longer as protective, and the most recent data suggests that it works against maybe 8% of the variants across the country, and that's probably an overestimate. Without that protection, I will be less willing to visit with friends indoors, travel, eat at restaurants, or attend indoor events, and choose the one that you most that most appropriately reflects your situation. Do you strongly agree with that statement, agree, neutral, disagree, or strongly disagree? The second question, how strongly do you agree or disagree with the following statement? I will feel comfortable attending an in-person CLL Society educational event that takes place indoors. Should we go back to doing indoor events like we did before the pandemic? Same spread of answers from strongly agree to strongly disagree. And the third question, at this point during the COVID-19 pandemic, which of the following ways, if any, has living with the blood cancer during the global pandemic impacted your mental health? Please select all that apply. So check as many as are appropriate. Have you had depression, anxiety, anger, and or frustration? A loss of the things that you used to enjoy, a sense of isolation, feeling of restlessness, lower self-esteem, feeling misunderstood by others. My blood cancer has not impacted my mental health since the start of COVID-19, or this question is not applicable to you. And the final question is, how strongly do you agree or disagree with the following statement? I would welcome the opportunity to participate in a clinical trial that offered possible effective pre-exposure prophylaxis or PrEP against COVID-19. And again, the same range, strongly agree or strongly disagree. So 4 questions, scroll down to get them all, and please start voting now. All right, and let's take a look at those answers. So in the first question, how willing are people? They would be less willing in about 3 out of 4 people strongly agree or agree that they're less willing without the protection of COVID to have these activities. So it's having a significant impact on the majority of people, 3 out of 4, the fact that the protection of Evusheld is no longer what it used to be during the summer. The next question is, how strongly do you agree or disagree? I feel comfortable attending events. And here, only about 15% feel strongly that they do. And again, the majority of people disagree with that they feel comfortable attending an event. So we hear you, and this is consistent with our plans, is to keep all our events virtual through the end of the year, but we'll be constantly reassessing this. I think this next question is very revealing, and I appreciate everybody's candor in answering this. But there, as we can see here, if you're feeling depressed, anxious, angry, particularly if you're the loss of things that you used to enjoy, you are not alone in these feelings. That a significant number of people are feeling the same kinds of issues. I think the loss of things was the number 1, followed by the sense of isolation. Number 3 was anxiety, worrying about when you're going out, what you're doing. Feeling misunderstood by others. I've certainly had that feeling, but also a depression and anger and frustration. Thanks everyone for their candor on that. And the last question is, how likely are you to consider, how would you entering a clinical trial? And I'm pleased to see that 7 out of 10 of you would feel strongly or strongly agree or agree that you would consider a different trial. And that's good, because there are trials coming up in this regard. So I think that gives us some great insight, and I think it's time to get the rest of the panel aboard. I'll welcome Dr. Mustafa and Dr. Chang to help answer the questions. We'll try to get to as many as possible. But let me start with a number of questions that we had here, which concern Evusheld. And I'm just going to try to focus on Evusheld. So we saw some disturbing data, and that data is even a few weeks old now, and the data now is not as good as it was even 2 weeks ago. So I'm going to ask both of you to answer this question. What are you recommending? A lot of people are due for a second Evusheld dose. people who've not responded to the vaccines, they tested, they have no antibody response. What are you advising your patients now in terms of the Evusheld? Should they be getting it? Why don't we start with you, Dr. Mustafa, and then Dr. Chang, if you could follow up.
Yeah, thanks, Brian. This is an important question that comes up a lot in clinical practice. And I think there's been different approaches at different institutions. And I've talked to a lot of colleagues at different places, and everyone's had a little bit of a different approach. There is no doubt that the efficacy, the effectiveness, the protection offered by Evusheld has significantly decreased. Even in early December, I thought it was going to be losing authorization, but it's still hanging around, even though the protection is significantly lower. The flip side is it's a fantastically safe, well-tolerated drug. So it really comes down, I think in medicine, I very rarely am dogmatic. I very rarely tell people what to do. I lay out pros and cons. So I have offered it to individuals who wanted it up to a couple of weeks ago, because I think the downside is not zero, but close to zero, and there may be some minimal upside. But again, with each passing day, it looks like it's decreasing. So that may be changing. It's dynamic, and everyone's situation is a little different. Social circumstances, vaccination history, history of previous COVID, illness, all of it. So it all goes into play. It's very, very nuanced. I think this is individual decision-making, with efficacy certainly decreasing, but safety being excellent. So very little to lose as add-on. Multiple other layers of risk mitigation. That's how I look at it. Andres, I defer to you for your perspective, and Brian, yourself too.
Yeah, well, thank you for having me, and thank you for the questions. I would agree with Dr. Mustafa in terms of it being an individual decision. That said, we have, with the data coming in every week showing that the variants that are more prevalent are the ones that are not, having any sort of protection from with Evusheld. Our institution has adopted essentially not encouraging patients to get it anymore. I still discuss this with patients. I don't think that anybody has gone against our recommendation of that this is not longer that useful. But instead, we have really stressed the fact of trying to get vaccinated and boosted, as opposed to trying to stress the use of this agent.
Let's follow up with what you just mentioned about vaccinations, Dr. Chang. If I've had no response to the vaccines, I may still be getting some benefit? Are there people are asking about T cell responses? So people are going out and testing. Do you recommend that they test for antibodies after they get the vaccine? And two, if they have tested, and the LLS was doing trials on this, and they find that they're not having any response, do you say, don't bother, or should they still go and get the boosters? What should they be doing? How are you handling that?
Yeah, those are excellent questions that come up with multiple patients that I treat. So in general, what I would say is, to begin with, is that patients who did not respond to the initial vaccination series, there's a subset of these patients that will respond to a subsequent dose. And there is data now that the more doses patients get, the higher what we call seropositivity rate is, which means that the higher number of patients will have detectable COVID antibodies. Now, that probably has to do with multiple factors. One of them is probably, if patients are treated with a venetoclax anti-CD20 type regimen, that as time goes on, this anti-CD20 antibody effect kind of wears off. And so I would still encourage patients to take to get vaccinated if they're willing to. There are also the effect of multiple exposures to the same antigen. We don't encourage patients to test for antibodies as standard of care at this point, because there's no data that suggests a linear relationship between the commercially available testing for antibodies and disease outcomes in terms of COVID-19 and CLL patients. We have data correlating neutralizing antibodies with outcomes, but those are not readily available. And so that's the reason why we don't normally encourage that. And also because, like you adequately mentioned, we are not assessing really what the T cell responses are just with this antibody test. And the jury is still out in terms of how well the CLL patients elicit a T cell response. That's still subject of further research. But again, I think, if you don't get a vaccine, then you have 0% chance of getting any sort of response. Whereas if you get a vaccine, at least you get some chance of getting a response and a boost.
So let me follow up on there's a lot of vaccine questions, as there should be. A lot of us got the bivalent vaccine 4 months ago, and in the past 4 to 6 months out, the immunocompromised have said time to get another booster, but we're not hearing that from the CDC or anybody else. One, do you guys, because you're closer to some of this than we are hearing whispers, is there a new bivalent coming? Should we be getting a second bivalent? How many boosters, should we be getting? What's the protocol for an immunocompromised patient? Dr. Mustafa, you want to take that one?
Yeah, these are all great questions. I agree with Dr. Chang. Everyone's vaccine series should be up to date, and I would highly recommend a bivalent booster. We don't want to be binary. It's not do you respond or do you not. It's how well do you respond. So I would argue most people, even with CLL, have some degree of response, even if it's suboptimal. Going forward, you're right, Brian. I mean, we're not hearing any recommendations right now for repeat dosing with the bivalent booster. And I have not been kind of uniformly recommending this to patients. And there's a lot of data still to be determined on the real world effectiveness of these vaccines, particularly in immunocompromised individuals. So I personally, and certainly would love to hear other people's perspectives, have recommended full vaccination series up to date, getting the booster, which most people got in the fall. Now we're at this window. Again, so much more goes into this. Many, many folks on this webinar have had natural infection. And when that occurred and how that may have been treated certainly impacts things as well. So right now, I think there's not much data to support additional bivalent boosters. I'm just going to give you a tiny caveat. It may be a little theoretical, but as an immunologist, there is a potential downside to over-vaccinating. It's a little bit theoretical. I don't want to get carried away with it. I certainly think as additional doses are recommended, it's appropriate, but I wouldn't recommend anyone to get a flu shot weekly for a year or something, an extreme. And that's actually because with too much vaccination, you almost dampen down your immune response to subsequent exposures. Almost, it's a concept called immune senescence. So there is a theoretical downside of over-vaccinating. I don't think we're in that world right now with COVID vaccines, but I've been kind of just waiting for the next recommendations about future vaccines from the CDC.
And the FDA is meeting on January 26th. That's an open meeting. We'll try to put something up on the website, and the public is welcome to attend that. And I think this will be an issue. Robin and I have been attending those meetings, and we think that they're hinting that they're going to be addressing that issue at this time. Here's another one that I think that there's some confusion about. And that is, people are saying, am I immunocompromised if I'm in watch and wait? Am I immunocompromised if I have monoclonal B-cell lymphocytosis, that precursor? Am I immunocompromised if I'm in a remission and I'm off of all meds? Dr. Chang, you want to take that for CLL patients and MBL patients?
Sure. So I would say in general, just by the simple fact of having the diagnosis of CLL or SLL, patients are already having some degree of immune compromise. I would say, you know, for those patients who pose that question, they probably will know somebody also that has had CLL that has never gotten treatment, but then they get this monthly IVIG before the pandemic, and that's because their immune, the amount of immunoglobulins are low. And so definitely, I would say we have data, conclusive data that the immune system is dysregulated with CLL and SLL. There's a little bit less data for patients who have MBL because this is just overall a more recently characterized kind of entity in which we think of it as a precursor of CLL and SLL. But I think that at least in my experience and in the studies that I've performed, we do see some degree of a change in the immune system and the normal immune response. And so because of that, I would say, you know, if you have this kind of diagnoses, one of these three diagnoses, that you should consider yourself as being immune compromised and act as if you are. That would be the safest approach.
The CLL Society pushed very hard to change the definition at the National Institutes of Health, the FDA and the CDC, to say all CLL patients are immunocompromised, regardless of their treatment status. And there are studies that show, you know, echoing what Dr. Chang says, that we do worse with COVID, have higher rates of hospitalization, ICU admissions, and mortality rates, regardless of our stage of therapy. Clearly, we respond more poorly if we're on active therapy, if our disease is raging out of control. But even for patients who've never been treated, we don't get vigorous responses to the antibodies, and we have a higher risk. So this was a big, important change to get the CDC and everyone to recognize that all CLL patients are immunocompromised. So let's talk a little bit about what the big concern here is. That it may be tough to avoid COVID, but none of us want to die. The mortality rates were horrific at the beginning. The studies out of Europe that the European Research Initiative and CLL, the collaborative there did, Eric, and the studies that were US based, over 30% mortality rates in patients. But the data is better now, isn't it? Dr. Chang, you want to take that in terms of the mortality rates and the morbidity, the hospitalizations and ICU admissions? What are you seeing in the data, and what's your personal experience with CLL patients these days?
Yes, so certainly at the beginning of the pandemic, the data was, like you say, horrific, and we were all concerned about that, rightly so. Fortunately, I think, you know, through a number of factors. One is, you know, the availability of vaccines, the availability of treatments, us as a healthcare system learning to treat these patients better, and develop novel modalities for treatment, and also as part of the viral evolution concept that I explained, you know, if you have a virus that is so pathogenic that it kills most people, then that virus cannot go and infect others, right? And so as part of that viral evolution, also we see that the infectivity increases, but also the mortality decreases. And so with all those things in mind, I think we are seeing that the mortality rates and also the hospitalization rates are decreasing. The studies tend to lag behind in terms of the data, and so we don't have essentially the most current wave, for example, but the most recent ones, which are talking about the early Omicron variants as well as BA.5, it puts hospitalization rates roughly between the 30 to 50%, and the mortality rates usually between a couple percentage points up to about 15 to 20%, depending on the study. But the caveat there is that the incidence is also much higher now than it is at the early in the pandemic. And so even though the percentage is low, there are more and more people that are infected. And so overall, from a scale standpoint and a raw number standpoint, we might still see a significant amount of people getting hospitalized and potentially dying from that.
Dr. Mustafa, is there anything you wanted to add on that in terms of what you're seeing in terms of the, because you treat a full spectrum of immunocompromised patients?
Yeah, I don't have numbers. And as Dr. Chang said, these numbers are hard. They obviously lag. By the time you submit a study, publish it, you're already months behind. But I think we should be very upfront in a very, very horrific situation going on almost 3 years ago. We've made tremendous headway in our knowledge, in our therapeutics, in our prevention, and in our outcomes. And I treat a lot of individuals with primary immunodeficiencies, like common variable immune deficiency, and certainly secondary. And our outcomes are much, much, much better. And I encourage individuals, and underreporting of infection right now is huge, right? There's so many people in society who have mild upper respiratory symptoms who aren't testing and reporting. I encourage individuals with CLL to still test for symptoms, report to a physician, and hopefully have early intervention with oral antiviral therapy, which has been proven to be hugely efficacious in decreasing hospitalization and mortality. But our outcomes are much improved. It is not the same data that we saw from 2 years ago, which is great. And I think we need to speak of the good stuff because there's plenty of bad stuff to speak about.
Well, there was a study out of Amsterdam, I think, and they looked at Dr. Nyman presented his paper at ASH, and in community-based, not hospital-based, but in the community-based CLL community, the mortality rate was less than 1%. Now that's still 10 times higher than the general immunocompetent population, where it's less than 0.1% the mortality. But 1% is a lot different than 37% like it was at the beginning. Dr. Mustafa, immune globulins, a number of patients get IVIG, people then test positive for COVID even though they've not had it. Is that providing any protection? And I just flashed on my screen 30 seconds ago, Elizabeth Cohen at CNN, the science writer there, she interviewed me and a number of other people about high titer convalescent plasma, and a paper was just released today on that. So I'm wondering if you can talk about IVIG and high titer COVID convalescent plasma, its role, in maybe even before you do that, if you could set this up. A patient asked, does their blood count relate to their immune globulin count? What does it mean if my immune globulin levels are okay? And here's another one. Somebody said, my immune globulins, I had great response to the vaccine. Does that mean I'm not immunocompromised? So I'm throwing a lot of immunology questions at you around immunoglobulin. Yeah.
Brian, I have short-term memory problems. I don't remember.
I'll try to sort them out.
No, let me give you a background. So there is very little correlation between your white count in CLL, SLL, and your immunoglobulin functionality. Potentially as more disease progression, potentially higher white count, maybe less immune function, but there's not great correlation. So I wouldn't put too much stock in that. I think I'm an immunologist, and when you go to Midas, kind of you get breaks, right? I think most, if not all, individuals with CLL deserve an immunoglobulin panel, IgG, IgM, IgA. That is the number of your antibodies, the size of your army. The problem is even individuals with normal antibody levels may have abnormal function. So it's a very rudimentary measure, but it's a place to start. If you have very low antibodies, that's concerning. If you have normal antibody levels, it's reassuring, although not perfect. The level might be fine, but the function, your army might be sleepy. So that's kind of where I start with the immune system. There are individuals, and there's papers on the role of immune globulin replacement in CLL, potentially decreasing infection. So if a diabetic doesn't make insulin, we give them insulin, right? So if people with CLL and hematologic malignancies aren't making adequate antibodies, we can give them antibodies. And we need to know that immune globulin, typically given intravenously, IV, but we do a lot of subcutaneous immune globulin also. But however you give immunoglobulin, it's IgG. So you're not changing your IgA or IgM levels, you're increasing your IgG. And it is a blood product donated by other individuals. If you're getting immune globulin today, Brian, it was likely that it's coming from plasma donations from 9 to 12 months ago. So that puts us back at what? That puts us in the summer of 2021. to late 2021. And by that time, many individuals in the United States in the plasma pool had COVID antibodies. It's a very, very long-winded way of saying that if you're getting immune globulin for CLL or any other indication right now, you're very likely to be getting passive immunization with COVID antibodies. Now, that's not today's antibodies. It may not apply to today's variants. It's so nuanced. It's from almost a year ago, but you are getting COVID antibodies, and they can be detectable with blood tests, things like that. So again, I mentioned this in my talk. No one should be asking for immune globulin for protection from COVID, because one injection only lasts, the half-life is 23 days, so a month or so. But if you're on it for other reasons, yes, you are probably getting some degree of protection. Dovetailing to convalescent plasma, I am not sure, and Dr. Chang, please correct me, step in with more knowledge than I have, of great studies on changing outcomes with that. And that's why I think there's such a heterogeneous approach. There are a couple of institution centers offering it for therapy, but most, I would argue, are not at this point. And again, it's the same concept. It's the delivery of antibodies. The dose hugely matters. Typically speaking, immune globulin replacement is going to have a higher dose of antibody than convalescent plasma, typically speaking. But again, so it's not being offered everywhere. There is chatter about it. Some centers are offering it. Dr. Chang and Brian, you both probably know more than I do on some of these recent developments. So please, chime in and compliment what little I said.
No, I mean, I agree with you that there's a lot of debate. I think even from the very early days in terms of using convalescent plasma for treatment of COVID. In our center, we have kind of gone back and forth at the beginning when we had not many good therapies. We would use it if we can get a hold of it. Nowadays, I don't think that we use it on a routine basis. Our center has learned, as with many other centers around the country, how to improve the care of patients who have COVID infections. And so with the institution of steroids and some of the other agents that I mentioned, and on top of some of the ICU maneuvers that we have, I think that for the most part, the vast majority of the patients will not be getting convalescent plasma at this point.
Today, and we'll put this up on the CLL Society website, there was an article published in peer-reviewed journal, which was a randomized control study in immunocompromised, and the recommendations are a little vague from the CDC, but they don't recommend for or against the use of convalescent plasma, but it is emergency use authorized, and we're hoping that this first randomized control study strictly in immunocompromised, and that would be, as we learned earlier, every CLL patient would therefore qualify for this, might be something to consider, especially because this is, and there was questions about this, polyvalent. This is going to be relatively fresh and recent variant, and has the opportunity. So there's some interesting things about it. Also, it's not as time sensitive is one of the things that I'm excited about. You don't have to get it in the first 5 or 7 days. It seems to be effective even on people who are very sick, on ventilators, other things like that. It does seem to help. So a controversial area. Let me go into some other controversial areas, and that is nasal sprays. There's one called Enavid, which is a nitric oxide nasal spray out of Israel. I'm looking at the weird faces. It doesn't look like either of you know about it. I'll tell you what I know about it. It's been shown to reduce the viral counts in nasal swabs. What difference that makes. Enovid is, I'm being told, is the way to pronounce it. Enovid out of Israel. From my point of view, there's almost no downside to it other than a little nasal irritation, drying. So have either of you heard of that, or? Nope. Okay. Well, we'll
I have not. That's for
Yeah.
treatment, Brian? So you're educating
It's a
me.
preventative. It's a preventative. So if you're out in the public and stuff, and the point that I would make is that no one, no virus has mutated around an N95 mask now. The N95 masks are still extraordinarily protective. Let's talk about a softer question, but a really important question is, and this has come up with a lot of people, what about, how are people handling making decisions about going to an event, should they risk it? They're the only one there with a mask. How do they tell their family, you need to be protective. I can't come to this dinner because I can't take my mask off to eat. What are you telling people psychologically? Because we saw what that survey showed, and we saw the level of anxiety, depression, sense of loss. How are you telling people to calculate what to do? And I know there's not a right answer, and everybody's decision is going to be different, but you counsel, all doctors, whatever your specialty, has to do a little bit of, psychiatric and social work too. That's part of what we do. And we're dealing with people that are depressed, anxious, locked up. So how are you helping these people? How are you helping them make these decisions? Maybe Dr. Chang, you want to go first on that?
Sure. Yeah, Dr. Kaufman, you bring a very important topic to light because it seems like, for the vast majority of society, we're more than ready to move on, and people were happy to get their mask off, get the concert started, get all these social events going, and then our patients are all like, well, what about us? And so I think that, when at least my approach when I talk to my CLL patients is, I'm not treating CLL, I'm treating a patient, right? And so and I'm responsible, and I should look after the overall well-being of the patient, and not just looking at the numbers and looking at CLL specific parameters. And I would say, with the improvement of our abilities to manage COVID infections, on the improvement of our knowledge in terms of how to prevent infections, early treatments, having vaccines available, I have had a lot of discussions in terms of balancing risk versus benefit. And I tell our patients, we have this data of higher risk of hospitalization, higher risk of mortality. But at the same time, that data is showing that we're improving upon that. We have antivirals available. You have gotten vaccines. Your family has gotten vaccines, or whoever you're going to be around have gotten vaccines. And so if patients and whoever else is going to be in that social circle are asymptomatic, then I think that, from a mental health standpoint, I would say, you should be able to do it. Just do like Dr. Mustafa in his presentation said, just common sense, right? If he's in an airplane, I probably would. If I was a CLL patient, I probably will wear an N95 mask, because that protects me as well as protects others. And then family members and dear ones, I would encourage people to try to live as normal as they can, while using common sense and trying to protect themselves through vaccination.
Dr. Mustafa, anything you want to add to that?
Yeah, I'm relieved to hear that me and Dr. Chang fall on the same page here. This is hard, and I think this is the beauty of the privilege of taking care of individuals. Everyone's different. And let's start there. And everyone's risk aversion, everyone's comfort level is different. So we really have to tailor this discussion. But we've had some numbers thrown at us in the hour, and I think they're important. Brian said that the paper from Amsterdam shows less than 1% mortality. That's still, it's meaningful, but that's relatively tolerable. The poll questions show us that close to 95% of people have been affected mentally by this, right? So the only outcome in COVID is not infection or hospitalization or mortality. there are many, many other very meaningful outcomes in COVID, and mental health is a huge one. I'm going to practice what I preach. My sister doesn't have CLL, but she's immunocompromised. We've taken, vaccination boosters, all those things Evusheld in the past. And it's incredibly important for her to socialize in family settings, get together for more important events. So is there risk there? There is risk. Is it managed risk? It is managed risk. So she has done it. And I encourage patients that I take care of, if you are comfortable with the amount of risk you're taking for the benefit you get, I highly encourage you to do these things. It's different to ask someone to take, social isolation for a month versus a year versus now 3 years and beyond. We can do a lot of things for a week or a month or 6 months, but the longer it gets, I think that needle changes. And Dr. Chang hit the nail on the head. It's a risk-benefit analysis. So I'm going to be very definitive. If people are comfortable attending family events, dinners, social events, I encourage you to do so with proper risk mitigation, because your risk won't be zero. But, it's a very kind of a cavalier way to speak, Brian, but you know how I speak. Is the juice worth the squeeze? I think it's hugely beneficial to have those social interactions, because what is life? Life is getting together with family, friends. The center of every culture on planet Earth I'm an allergist. I do food allergy too, right? Is eating. We eat. We get together. So this is all very, very important. So I can't overstate the importance of doing those things that are important to you while taking some common sense.
Wow, that's both so helpful from both of you. And
yeah, let me add something to that too, if I might. COVID is not going to go away, right? Like, we know that by now, and so we just have to learn to live with it. The other thing that we're going to start seeing is that, and we're already seeing, is that COVID also will probably come in waves, right? And so waves means that there are times where there's a higher incidence versus times that are lower incidence. And so I would say, if for the risk also changes depending on the incidence across the country. And so for times that are lower incidence, meaning our valleys, we're probably saying, it's probably safer to do certain activities than when we're at peaks. And so that would be also should be also be taken into consideration.
And there's all these factors that you weigh in. Is it indoors? Is it outdoors? Is it well ventilated? What's the prevalence in the community? All of these kinds of things that you can weigh in. And I'm constantly making decisions. Is it worth it? Is the juice worth the squeeze? To see my grandkids, for me, I make that decision. I'm going to get on a plane. I'm going to wear a mask, but I can't go 3 years without seeing grandkids. Is it a risk? Yeah, they go to elementary school. They could bring home things. Absolutely, it's a risk. Is it worth it for me to go to a hockey game? As much as I love ice hockey, being from Canada, no, I'm not going to sit in there with screaming people, me and 3 other people out of 25,000 wearing a mask. It's not worth it. I just won't go to an ice hockey game, which I love to go to. So we all make these different decisions about what we're willing to do and not willing to do. Let me talk about the infection itself. And Dr. Chang, maybe you can talk a little about this. First, should we be worried? We've heard that the monoclonal antibodies don't work anymore. What about the antivirals? Are they still working against all the strains? So I'm going to throw a whole bunch at you, so I'll test your short-term memory. What about if you're on ibrutinib or other meds? The Paxlovid is pretty tricky in terms of drug interactions. Is there any advice you have for patients there? And then the last is, what about this rebound? And is 5 days enough for the immunocompromised? If we test positive again, should we get a second course? So I'm throwing a lot of Paxlovid, but also the other antiviral questions at you. So let's start first with any resistance issues that we're seeing with these, like we've seen with the antibodies and the vaccines.
No, as far as I'm aware of, we haven't seen any significant resistance of newer variants against either of the agents that we have approved under EUA for treatment, any of the oral antivirals. And so I think that it's, they should be equally effective. Usually the variants will come in when they change the surface proteins for the most part. They do change some of the internal parts, but mostly they change the surface proteins, which is the way they escape these antibodies. And that is not necessarily being the target of our oral antiviral agents. The other question that you brought in is in terms of COVID rebound. As I mentioned, most likely patients who have COVID rebound, that just essentially shows potentially some under-treatment in terms of disease treatment course. So for some patients, 5 days might not be enough. In other words, there are talks and about whether it's safe to retreat with, in this case, Paxlovid, which is the most common agent that we use nowadays. I don't think that there's any safety signals that will say don't treat again. But at the same time, with an emergency use authorization, it becomes somewhat tricky to prescribe things outside of a very narrow indication for which it was approved. And so while I don't think that there's any downside or the downside of treating with Paxlovid again is small, I'm not sure that many people can actually do that. And as I said, the clinical significance of a rebound is still unclear. And so I'm not sure that we even, we need that anyways. And then I'm guessing
interactions.
The drug interactions. Yeah. So both molnupiravir and Paxlovid, they both have drug-drug interactions with different agents, and as we learn more and more about how to administer them in our CLL patients, some of the recommendations change. And so I think at the time that our particular patients need it, we usually ask them to call us. We don't give them prophylactically ahead of time for a trip, for example. That's not an approved indication for once, but also we do want to know what's the latest in terms of drug-drug interactions so that we can adequately advise in terms of whether we need to stop a drug and for how long in order to get the treatment in.
Okay. I'm just going to make a couple comments on Inovid and go back to that. There's a trial going on in Canada right now looking at its effectiveness for pre-exposure prophylaxis, see if it can be used as a way to prevent disease. And so it is being looked at. And I will share personally that I use it when I think I'm in a high-risk circumstance. When I went to ASH with 27,000 other people, I relied on N95 masks, but I used Inovid every morning and every evening. So I don't see much downside to it other than the cost of it and a little bit of irritation in the nose. Let me ask another follow-up question on this testing positive in the rebound. There is somebody who has CLL who got Paxlovid, tested negative, then tested positive again later, and now weeks and some people months later are testing positive. When are they, when are they safe? What does this mean? How do you, I'm sure you have a few of these patients in your practice. What are you telling these people? What can they do? And it's very different if you're immunocompromised. How do people handle this? You want to take that, Dr. Chang, or I know it's a tough one.
Yeah, sure. So we do have a couple patients like that, and I think that even from earlier days, right? Like we know that some patients with hematological malignancies will have this prolonged time in which they test positive for COVID. Sometimes they even become asymptomatic and they still test positive. I think, there's a lot of nuance in terms of the testing and what it truly means to be positive and how positive it is, right? Like we always like this black and white, positive versus negative, but in reality, all the testing is somewhat of a gray area. And so for patients who had this kind of rebound, is really individualized in terms of what we advise these patients. If they're feeling fine, then we probably would just let it go, or, let it be. If they are symptomatic and they are becoming sicker, then we would talk about consideration of trying to maybe trying another dose of Paxlovid if we can get it. And so it really depends on that particular situation.
And let's ask a little bit about the use of remdesivir on people who haven't responded to Paxlovid. Did you want to take that, Dr. Mustafa, or people in hospital, remdesivir? I know that there's now a different protocol. We're using sometimes like a 10-day instead of the 3-day. And could any experience or knowledge on it to help patients?
Yeah, so remdesivir again is another antiviral, so not disease specific, right? And it's IV though, so it's a little bit different than Paxlovid. And it's been used routinely in the inpatient setting, 3 days, but longer now too, Brian. And there are some institutions who have managed to deal with the logistical hurdles of offering remdesivir as an outpatient for high-risk individuals. Not many, because it's difficult to have a 3-day IV infusion protocol consecutive with some blood work and things like that. So many have not been able to do it for a variety of reasons, but there are some. It's a study called the Pinecone study that showed that. So remdesivir, much like Paxlovid and antivirals, remains effective and remains a therapeutic option, certainly in the inpatient space and in limited parts of the country in the outpatient space too, Brian. But I want to just dovetail on what Dr. Chang said about these these individuals who test persistently positive. They do tend to be immunocompromised. We have a few here too. The first thing I tell them is, I don't know what to make of this. I think we have to be honest. We don't. There's no way to scientifically tell someone when they have no more infectivity or not. It's very hard to believe they would be infected for weeks, which we have seen some individuals in our center, and there's reports of it in the literature. So the first thing we have to be is honest with how much we don't know. And then there are a bunch of trials and therapeutic interventions we can try to intervene with if they're symptomatic. If they're asymptomatic, I kind of heard Dr. Chang allude to it. I tell them to stop testing. Like, I don't know what to make of it. You're not feeling anything. Stop checking. It's hard to know how to interpret the result in medicine. You don't order a test unless you know what to do with the result either way. But if you're symptomatic, there are certain strategies and reports that it's a very, very uncommon individual, but it happens.
So not so much in our population, but our population does have questions about the vaccines. And I'm going to introduce, and you are, as an immunologist, a vaccinologist too, you've sort of inherited that title. So some people are concerned there, and there was an article that came out in CNN on the Moderna not being as transparent, that a lot of press about that. Does that give you any pause? And I also had a question about people, and I think these are legitimate to ask. They're worried, are there additives in? We're not talking about Bill Gates and putting a microchip in the vaccine. We're talking about, are there additives? Some people have allergies. Aren't there things called adjuvants that are added? Is there coloring? Is there, you're an allergist, so you know that sometimes it's not the medicine, it's the other stuff that's in the capsule that the person has the allergic reaction to. The colored dye to make the pill look pretty. Are there concerns about this with vaccines? Could you address some of those safety issues? And I'll just to test your short-term memory. What about the cardiac issues? What about the myocarditis? Things like that, because people, we're dealing with an older population. People have heart disease, they have concerns. So could you address those with your patient? I'm sure patients must grill you on this stuff too.
Yeah, so I'll start with my allergist hat because that's the easier part of this question. Vaccine Allergy is extraordinarily uncommon, but absolutely reported. This has happened well before COVID. We've been vaccinologists, Brian, for my entire career. I've been on guidelines for vaccine allergy adverse reactions. In general, if you take all vaccines together, for every million doses you administer, someone will have a true allergic reaction. So it's about a 1 in a million risk. For COVID, initially it looked like it was higher, but at the end of the day, it's really settled out at about maybe 2 per million, maybe 3 or 4 per million, maybe 1 per million. So not that different. So although allergic reactions are possible, they're extraordinarily uncommon. Allergic reactions, most individuals know how to treat them with either epinephrine or antihistamines in the acute setting. Very interestingly, if you've had an allergic reaction to a vaccine, please make an appointment with your local allergist. We can safely administer vaccines that you have a true allergy to. First of all, you should be evaluated to even see if it was a true allergic reaction. When I say allergy, I'm talking about an IgE, antibody-mediated immune reaction that puts you at risk for anaphylaxis. So, people think about milk allergy can cause anaphylaxis. It's different than lactose intolerance. It's not fun, but it's not an allergy. So the words do matter. So if you think you're allergic to a vaccine, see an allergist, because there are some testing protocols or even ways to desensitize you to a vaccine. Then you get to non-allergic side effects, Brian, and I'll tell you what excites your immune system the most is proteins. Proteins they elicit immune responses. Sugars, fats don't elicit immune responses nearly as much as proteins. That's why certain vaccines, conjugated vaccines, like Prevnar for pneumonia, are much more immunogenic than Pneumovax, which is a sugar-based, a polysaccharide vaccine. I'll give you another example in a very societal way that we understand. People are allergic to peanuts, but people who are allergic to peanuts can usually tolerate peanut oil 99% of the time because oil does not have protein, it's fat. So all the other stuff that goes into the vaccines are usually non-proteinous materials. So they're not hugely immunogenic. And this has been studied with MMR, with other influenza vaccine. Even the stuff you put in, like egg-based influenza, tends not to be immunogenic. So the bottom line is that vaccines are extraordinarily safe, but of course, nothing is zero risk. We've talked about this now ad nauseum. There is some small risk, but I think the benefits far outweigh the risks. I just got those headlines about the FDA and the lack of potentially transparency with Moderna. I'm not well educated to speak in a really detailed manner. I will say that I used to say the half-life of information in medicine is 7 years. Every 7 years, half of what we thought we knew was kind of wrong. It feels like in COVID, the half-life of information is 7 weeks or 7 months. It is changing very fast, and the timestamp on these studies has really, really sped up. I think we're going to talk about the supernova study with Evusheld 2.0 before the end of the hour. And as knowing about how that is, they're trying to do site selections and enrollment. It is very, they're hitting all the safety steps, but it is compressed and faster. So I think that may have played a role. I don't know the details of the question with the vaccine stuff. But these are fair questions. Safety is paramount. We start with do no harm. But I do truly believe as an immunologist, most vaccine formulations are highly safe and well studied in the setting of good efficacy.
And the heart inflammation, is that an issue? The cardiac inflammation?
Yeah, so it has been, but it was actually reported in a younger population, right? With certain vaccines, with certain intervals. It looked like the interval mattered of dosing as well. So much nuance, but again, we're a little bit right now captive by the unicorn, right? The outlying side effect that gets some press. I'm not saying it doesn't happen, but the risk is so low compared to the benefit, which is undeniable. So these are very fair questions that we should be aware of. But again, I think the risk-benefit analysis really falls on the side of vaccination.
Well, you teased us with the supernova trial. Could you tell us about that trial? Because there's a lot of questions about Evusheld V2. Do you have some information on that you can share?
So I was looking at the Q&A and saw tons of questions about that. As the efficacy, effectiveness of Evusheld is waning, the company is working on kind of a second product for prophylaxis. They are, I do know, looking for research sites right now. It's going to be an international trial. not just US, Europe too. Dr. Chang, Brian, you guys probably know more about this than I do. They're in the process of site selection and setting up with enrollment coming, I think, in weeks, hoping to enroll all subjects by August, and then having data come out and then potentially, approval going forward. I think an important point of this trial is, unlike the first Evusheld study, the PROVENT study, the definition of high risk in this study is this group. It's individuals with CLL, hematologic malignancy on significant immunosuppression. The definition of immunocompromised or at risk in the PROVENT study was a much lower bar. Advanced age, 65, I don't even consider that advanced age as I get older. Any medical condition would qualify you. So the selection is for a much more high-risk population, folks with CLL. It's moving along quite fast with enrollment this year, with hopefully some information by the end of the calendar year. So it's not tomorrow or next week, but that is fast for a clinical trial.
And I would add that a number of other companies, Invivyd and Regeneron, are also looking at pre-exposure prophylaxis trials and hope to launch those maybe as early as this quarter, next quarter. So there are other possibilities coming in that regard. Talk to me, while we're talking about vaccines, how is it that a CLL patient, we had this question, can not get antibodies to the vaccine, but have a horrible reaction, have a fever and achy pains and feel like crap, like they had the flu? And, separate out this immunogenicity versus the reactivity of the vaccine, because it's confusing.
It is confusing, and there's actually contradictory data. So the response you get to a vaccine, the muscle aches, the pain, the potential fever, is a very different part of your immune system than your antibody response or your T-cell response. So that's different. I have said for the duration of this pandemic, and I still believe this actually, that it doesn't correlate with your antibody response. Feeling crappy after vaccine does not mean you're making great antibodies, and vice versa. Some people don't even know they got vaccinated, but they make great antibodies. And there are multiple studies that suggested that. There was recently one pretty well done study, but just one that said kind of the cruddier you felt after vaccination correlated with antibody response. I tend not to fall in that school. It was just one study. More have said there's no correlation. And the difference, the disconnect, Brian, is it's like you see this local foreign invasion from the antigen, and you have local cytokines responding, inflammation, redness, swelling, pain, which is very different than the part of your immune system building antibodies, T cells. So it is pretty discordant. I don't think people should be trying to predict their antibody response for how well they felt or terrible they felt after vaccine, but there is a little bit of push and pull in the literature of, does that feeling within the first 48 hours have any effect on antibody response?
We also had someone comment that there's an Inovid trial going on in Israel too. So, I mean, there is some buzz about the nasal sprays. The nasal vaccines have been disappointing, the early data on those. Let me just ask that, and then I'm going to ask for summaries here, and I'll push you again on the vaccines. Why can't we get a vaccine that stimulates the T cells? Why can't we get a vaccine that is going to work better or more durably? Why do we always have to pick on this spike protein because it keeps changing all the time? Isn't there a part of the virus that doesn't change? Can't we make a vaccine or an antibody against that? Is there, is there a piece of the immunology that just makes this very difficult? You want to take that? I'll give that to the immunologist again. You're dodging these, Dr. Chang.
I was trying to pretend I was hitting unmute because I was trying not to, though, because I answered the questions too hard.
Yeah. I'm happy to answer to take a stab at those too. Yeah. So I think that there are a couple of reasons why we talk about the spike protein too much or a lot. I would say one is it's in the surface, is what we see, is what our immune system sees initially, and frankly, it's the is what is being recognized the most by our B cells and our antibodies, and they're really excellent assays and really good at easy to conduct assays to measure these antibody levels and the neutralizing activity and so forth. Measuring T cell responses is a little bit more difficult, right? For one, you have to process the cells and isolate them in a way that you can actually test them later, and the testing is a little bit trickier. They recognize the spike protein, but they can also recognize other proteins that are in the virus. They just don't attack the virus in of itself, but they recognize the infected cells as opposed to the virus itself. So the studies are a little bit more challenging. In fact, I would say, our current mRNA vaccines do elicit a T cell response. We don't hear a lot about it as of yet because they're more difficult to conduct. And so, for a lack of a better word, our vaccines are also T cell vaccines, not just a B cell vaccine. I don't know if you wanted to add something else, Dr. Mustafa, to that.
I love it. You did the heavy lifting. Thanks.
And the big thing about vaccines too is they stimulate the full immune system, where as good as Evusheld was, it was passive immunity as an antibody, no T cell involvement, no the innate immune system, none of the other parts of the immune system that the vaccine hypes up the whole immune system going. So that's, if you do respond to the vaccines, and not everything can be measurable with a simple blood test that you get at Quest, it tells you a level there. So we're down to the last a few minutes here. There are a couple real quick, short, practical questions. How long, if you've had a COVID infection, which a lot of people have had now, how long should they wait to get vaccinated? Is there a number on that?
I think it's been the moving target. Scientifically, it's honestly safe to be vaccinated once you feel well and kind of back to baseline, scientifically. And that, for most people, if you want to ballpark it, it's 2 weeks. There was some argument to wait up to 3 months after, not because it's dangerous to do it sooner, but there's an assumption if you had COVID infection, you may have some natural immunity. So you let that kind of hang in there. And as that maybe starts to wane, you come in with a vaccine. I think it's, again, individualized comfort levels. There's no danger in getting it when you start feeling well. You just don't want to get a vaccine when you're febrile and sick because you're not going to feel well. But shortly thereafter, I think any time is fine. And the reason to wait is to kind of increase that duration of natural immunity.
Yeah, I totally agree. And I'm in the camp of waiting for a couple of months to take advantage of that natural immunity before I vaccinate.
I think the CDC guideline is 2 months, but I think it's a soft guideline. It's not a rigid guideline. So, all right. Dr. Chang, are any final thoughts or things? We've really covered a lot of material, but any final thoughts or messages that you wanted to give the CLL community in terms of what they should take away from this?
Yeah, so I would say, I'm more on the optimistic side, and so I would try to encourage, our patients, try to live as normal of a life as possible, knowing, what the surrounding is, knowing what the risk is for your particular scenario, but also knowing that we have treatments available, we have vaccines. We should all encourage every one of our patients to get vaccinated. But also one of the things that we didn't touch too much about is, and I want to stress that, is that we should encourage our loved ones to be vaccinated, right? And because that builds a bubble around our immune-compromised patients that will eventually lead to protection and decreases the chance of that particular patient getting sick. And so I will live with that, is to vaccinate yourself and also encourage vaccination of your close family members.
Dr. Mustafa, last word to you.
I agree completely with Dr. Chang. I think we fall in the same camp that this is another viral illness that's kind of here to stay. So I encourage everyone to live their life with common sense risk mitigation. The concept of cocooning is great. And I'll comment on one thing. I think individuals get very frustrated by other folks who may not take similar strategies for protection, may not be vaccinated. We're looking to gain immunity here, right? And unfortunately, it's not the best way to gain immunity, but natural infection is also a way to gain immunity. There was just a study published in children that 90% of children in the US have likely been infected with COVID. So there is a lot of community immunity floating around, which leads us to say things like, do the things that are important to you. Like Brian said, seeing a grandparent child on a plane is important. Hockey is great, but you can pass on the $20,000 indoor arena. So do the right things. Know there's treatment. If you are having symptoms, do test, report to your physicians, because there are very, very well tolerated, effective therapies. And I commend everyone for being so engaged in their healthcare. And thanks for making me a part of the program today.
Yeah, thank you for inviting me as well.
I think this was amazing, and I'm so grateful to our presenters here, Dr. Chang and Dr. Mustafa. I think the discussion and I also want to thank you for keeping your presentation short, because I mean, I have, the counter only goes up to 100 questions, I mean, so we didn't get through them all, but I wanted to thank people. This program was made possible by support from AstraZeneca and Beijing, and we're very grateful for that. I want to thank all of you who joined us today. A big thanks to Dr. Mustafa, Dr. Chang, and Robin, of course, who's been answering your questions and funneling me information and elbowing me virtually to remind people of how to pronounce names and studies that were ongoing. If we didn't get to your question, and I know we didn't get to a lot, email asktheexpert@cllsociety.org, asktheexpert@cllsociety.org. In less than a month from now, we have another webinar, which we'll be reporting from ASH 2022. Yours truly be one of the presenters, Dr. Samir Parikh from Mayo Clinic, which a lot of you know will be covering. We've picked about a half a dozen of the top papers from ASH, and we'll be presenting that. There will also be some stuff on COVID, but it'll be mostly on CLL. Please complete the event survey, provide your feedback. We really do read it. It's really important to us. This event was recorded and will be available on the website. We usually say within a week, but Brad, our IT guy, usually gets it up sooner than that. And please do remember the CLL Society, we're a nonprofit. We're invested in your long life. Please invest in the long life of the CLL Society by supporting our work. And as our motto is smart patients get smart care. I can't imagine anybody is leaving this session not at least a little bit smarter than when they arrived. Stay strong. We are all in this together. Thank you to everyone for making this incredible webinar.
Thanks, guys.
Thank you very much.
Thanks.